Have you ever just felt completely buried under all the health information out there? I mean, every day it feels like there's a new headline, a new study,
Yeah,
a new recommendation. It's a lot. How do you even begin to separate what's truly important from just, well, more information?
yeah.
Today, our mission in this deep dive is really to cut through that noise. We want to equip you with some critical, impactful insights into two huge areas: cancer screening and a major preventable health risk, smoking. We're aiming to get straight to the knowledge you actually need.
That's precisely it. And cancer, and unfortunately, it's still the second leading cause of death in the United States. So effective screening and prevention are just incredibly vital.
Yeah.
Our goal today isn't just to rattle off a list of recommendations. We want to go a bit deeper, explore the science behind them, and really empower you to understand the why behind these critical health decisions you might face.
Okay, let's unpack this then. We're going to dive into something really fascinating and maybe even a bit surprising about cancer screening that often gets overlooked: the methodological issues. I mean, what if finding a disease earlier doesn't actually mean you live longer? That sounds kind of backwards, right?
It absolutely does. And it brings us straight to two common biases in screening that are just crucial to understand. The first one is lead time bias.
Lead time bias.
Think of it this way. Say there's a new test, and it can detect pancreatic cancer maybe 3 months before it would have shown any symptoms.
Right.
So if a patient gets this early diagnosis, their survival time from diagnosis seems to increase by 3 months.
Ah.
But, and this is the key, if the disease is still ultimately incurable, the test has only found it earlier. It hasn't actually changed their overall mortality.
So they still pass away at the same point in time?
Exactly. They just knew about the disease for longer. The lead time was extended, but not their lifespan.
Wow. Okay.
And there's the second one, length time bias.
Length time?
Yeah, this is more about the nature of the cancers themselves. Not all cancers grow at the same speed.
Like some are slow, some aggressive.
Precisely. Some, like certain prostate cancers, grow very slowly, maybe never even cause problems. Others are aggressive, rapidly fatal.
Okay.
Now, screening tests, they are inherently more likely to pick up those slower growing, less aggressive cancers.
Why is that? Just because they're around longer?
Exactly. They simply exist for a longer period, providing more opportunities for detection. So this can make the screened population appear to live longer on average.
Because you're diagnosing more of these indolent cases.
You got it.
Yeah.
Even if the aggressive cases still lead to similar mortality rates, whether
Yeah.
they're caught by screening or not.
That's a lot to think about. It really changes how you view early detection. So if I'm listening, trying to make sense of this, it sounds like the real goal, the North Star for screening, isn't just catching things early.
Right.
It's about actually reducing the number of people who die from that specific cancer. Is that the ultimate measure?
That is precisely the point. The very best measure of a screening test's true effectiveness is a demonstrated reduction in disease-specific mortality.
Fewer deaths from that cancer.
Exactly. Not just an earlier diagnosis, not just an apparent increase in survival time after diagnosis. And it's challenging because proving that requires these huge long-term studies, randomized controlled trials, to really show a screening program saves lives from that specific disease.
Right, isolating that effect.
And when you're looking at any test, it helps to understand a few key characteristics, like sensitivity.
Okay.
Sensitivity is the test's ability to correctly identify people who have the disease. The mnemonic SNOU. High sensitivity helps rule out T disease. If it's negative, you probably don't have it.
Got it. SNOU. Rule OT.
And there's specificity. That's the test's ability to correctly identify those who do not have the disease. The mnemonic there is ISPIN. High specificity helps rule in disease.
ISPIN, rule in. So a positive means it's likely you have it.
Very likely, yes, especially with high specificity. And beyond those, you have positive predictive value, or PPV.
PPV.
That's the proportion of people with a positive test who actually have the disease. And this one is really, really dependent on how common the disease is.
How so?
Well, even a super specific test can have a pretty poor PPV if the disease is very rare in the population you're testing. You'll just get more false positives relative to true positives.
Ah, okay. That makes sense.
And finally, negative predictive value, NTV. That's the proportion of people with a negative test who truly don't have the disease. This tends to be higher when the disease isn't very common.
Okay, so we've got the theory down: lead time, length time bias, sensitivity, specificity, PPV, NPV. Now, the real question I have, and I bet our listeners do too, is how does this all translate into actual recommendations for us?
Right.
Because here's where it gets really interesting. We're going to move from that foundational understanding to the specific, impactful recommendations for common cancers. And, you'll see that expert organizations sometimes differ slightly.
They do.
Which really just underscores how important that informed shared decision-making with your doctor is.
Absolutely. Let's start with breast cancer screening. It's significant. It's the second most common cause of cancer death in women overall.
Wow.
And notably, it's the leading cause of cancer death in women aged 40 to 59.
That young.
Yes. The single biggest risk factor is age, but family history is also incredibly important. Having one first-degree relative, like a mother or sister with breast cancer, that doubles your risk.
Doubles it. 2
or more first-degree relatives quadruples it.
Wow.
And we also see increased risk with specific gene mutations like BRCA1 and BRCA2. And it's worth mentioning, BRCA2 mutations in men increase their risk for breast, prostate, pancreatic cancers, and melanomas too.
Understanding those risks is crucial, but so is understanding that whole benefits versus harms debate in screening, right?
Absolutely essential.
While mammograms do demonstrably reduce breast cancer deaths, there are potential downsides we have to acknowledge. Things like false positives, which must cause huge anxiety, right? And lead to maybe unnecessary biopsies.
They certainly can. Significant anxiety, extra procedures, costs.
Right.
Yes. And then there's the concern of overdiagnosis and overtreatment.
Finding cancers that might never actually have caused a problem.
Exactly. Cancers that are so slow growing they wouldn't have impacted the woman's lifespan. Treating those leads to the harms of treatment without the benefit.
So it's this really complex balance.
It is. And that's precisely why that shared decision-making piece is so vital. You need to weigh these factors together with your doctor.
So what are the actual guidelines saying? I know they differ.
They do. Let's look at average risk women. The USPSTF, the U.S. Preventive Services Task Force, in their latest 2024 guidelines, recommends biennial mammography, so every 2 years, for women aged 40 to 75.
40 now. That's a change, right? It used to be 50.
That's right. They updated it, lowering the starting age based on new evidence analyses. But for women 75 or older, they make no recommendation due to the insufficient evidence.
Okay. And the American Cancer Society?
The American Cancer Society, ACS, their 2015 guidelines recommend annual mammography for women 45 to 54.
Annual.
Then biennially, every 2 years, for those 55 and older, as long as their life expectancy is at least 10 years. For women 40 to 44, they say they may consider annual screening. It's an option to discuss.
A bit more flexible there. And the American College of Physicians?
The American College of Physicians, ACP, in 2019 recommended biennial mammography for average risk women aged 50 to 74. They say discontinue at 75, or when life expectancy is less than 10 years.
So they stick with 50.
Yes. And for women aged 40 to 49, they advise specifically considering the risks and benefits before screening. So more caution there.
Okay, so we've got different ages, 40, 45, 50, and different frequencies, annual, biannual. For someone listening, this can feel really confusing.
Understandably.
What's the core disagreement, especially for women in their 40s? Are they just looking at the same data differently?
That's a big part of it. While everyone agrees on screening women aged 50 to 74, the debate for the 40-49 group often comes down to how you balance the absolute number of lives saved against those potential harms. The false positives, the overdiagnosis in an age group where breast cancer is, statistically, less common.
So fewer cancers to find, but still potential harms from looking.
Exactly. Some guidelines prioritize saving every possible life, even if it means more women undergo unnecessary procedures. Others lean towards minimizing those harms, arguing the benefit might not outweigh the risks for all women in their 40s. It's a different weighting of the evidence.
That makes a lot more sense. It really drives home why it has to be a personal conversation.
Absolutely.
And just quickly, things like clinical breast exams aren't really recommended for average risk women anymore?
Not generally, no. And MRI screening is usually reserved for very high-risk groups, like BRCA carriers. It's highly sensitive, but costly, and has more false positives for average risk women. So often starting MRI around age 25 or 30 for those specific groups.
Got it. Okay, let's move on to colorectal cancer screening.
Right. This is the third leading cause of cancer death in the U.S. But there's some really good news here.
Oh, yeah.
Incidence and mortality rates have actually dropped significantly since the 1980s.
That's fantastic. Why?
A key reason is how most colorectal cancers develop. They usually start as adenomatous polyps.
Polyps. Right.
And these polyps give us a valuable window for early detection and, importantly, removal. For instance, about 10% of polyps over a centimeter in size might become cancerous within 10 years. Screening lets us find and remove them before they turn into cancer.
So you can actually prevent the cancer, not just find it early.
Exactly. That's a huge advantage of colorectal screening.
And the really encouraging part here you mentioned is that there are several effective screening methods. All the proven ones reduce mortality, so it's not like there's only one best way.
Correct. It's about finding the method that works best for you, that you'll actually do. We can group them into sort of stool-based tests and structural exams.
Okay, stool tests first.
You have the fecal occult blood test, FOBT, or the fecal immunochemical test, FIT, usually done annually. And then there's multi-targeted stool DNA testing, often called FIT-DNA, done every 1 to 3 years.
And the big plus for these is convenience, right? No bowel prep.
Exactly. Done at home, no special diet beforehand, usually no sedation needed. Very convenient. But it's really important to note, there are some FDA-approved blood tests out there, like one called MSE-PT9, but these are not currently recommended by major professional societies for general screening. Stick to the proven stool or structural tests.
Good to know. Okay, what about the structural exams?
These actually look inside the colon. You have flexible sigmoidoscopy every 5 years, CT colonography, sometimes called virtual colonoscopy, also every 5 years, and then the full colonoscopy, typically every 10 years for average-risk folks with normal results.
And the trade-offs here. Sigmoidoscopy is less invasive than colonoscopy?
Yes, it only looks at the lower part of the colon, so less prep, usually no sedation. But it can miss polyps higher up. CT colonography requires prep but no sedation. Colonoscopy sees the whole colon, very sensitive, allows polyp removal during the test, but requires the full bowel prep, usually needs sedation, and carries slightly higher, though still small, risks of complications like bleeding or perforation. And if a polyp is found during sigmoidoscopy or CT colonography, you generally need a follow-up colonoscopy anyway.
Right. So lots of options there. What about people at higher risk, like family history?
For high-risk groups, the recommendations are definitely more aggressive,
Yeah.
usually centering on colonoscopy. For example, if you have a first-degree relative, parent, sibling, child diagnosed with colorectal cancer before age 60.
Yes.
Screening with colonoscopy should start at age 40, or 10 years before the age your youngest affected relative was diagnosed, whichever comes first.
Okay, 40 or 10 years younger.
And then repeat every 5 years, not 10.
Every 5. Got it.
And there are also very specific different guidelines for conditions like inflammatory bowel disease or inherited syndromes like Lynch syndrome or familial adenomatous polyposis. Those require specialized plans.
Makes sense. So, summarizing for average risk folks, most societies now say start screening at age 45.
Yes, most major groups recommend starting at 45. The American College of Physicians is a bit more conservative, recommending starting at 50, but discussing it for the 45-49 group.
And when to stop?
Pretty good agreement there. Generally stop when life expectancy is less than 10 years. That usually translates to around age 75, though some guidelines allow for individualizing up to age 84 based on health status.
Okay. Next up, cervical cancer screening.
Right. And the key thing to know here is that the most significant risk factor for developing cervical cancer is infection with the human papillomavirus, HPV.
HPV. And the traditional screening method has been the pap smear, right?
That's right. And interestingly, on its own, the pap smear actually has a relatively low sensitivity, maybe around 50%.
Only 50%. How has it been so effective then?
Because of that long lead time. It takes, on average, about 10 years for high-grade dysplasia, the precancerous changes to potentially progress to invasive cervical cancer.
Ah, so you have lots of chances to catch it over time with repeated tests.
Exactly.
Yeah.
That slow progression is why regular pap smears have been so successful. We've seen like an 80% drop in mortality since it was introduced. It's a true public health triumph.
Amazing. But now we also have HPV testing, right? And co-testing.
We do. Adding HPV testing, either alone or combined with the pap smear that's co-testing, significantly boosts the sensitivity, finds more potential problems.
So why not just do HPV testing on everyone?
Well, here's a key point. HPV testing is not recommended for women under 30.
Why not?
Because transient HPV infections, ones that the body clears on its own, are incredibly common in younger women. Testing them would lead to a lot of unnecessary anxiety and follow-up procedures for infections that were never going to cause cancer anyway.
So the infections that stick around, the persistent ones, are the real worry.
Precisely. And those persistent infections, which are more likely to progress, become more common in women over 30. That's why HPV testing is much more valuable in that age group.
Okay, so what are the current general guidelines?
All right, for the general population, No screening needed before age 21.
Okay.
Ages 21 to 29. Cytology, the Pap smear alone, every 3 years.
Pap every 3 years for the 20s.
Then, ages 30 to 65, you have options. You can continue with cytology alone every 3 years, or you can do FDA-approved primary HPV testing alone every 5 years, or you can do co-testing Pap plus HPV every 5 years.
So more options, longer intervals if HPV testing is involved.
Correct. And screening can usually stop after age 65 if a woman has a history of adequate negative prior screening results.
Good to know. And does the HPV vaccine change any of this? If you're vaccinated, do you still need screening?
Absolutely, yes. The HPV vaccine is fantastic, but it doesn't cover all cancer-causing HPV types.
Yeah.
And it doesn't help if you already had an infection before vaccination. So current screening guidelines remain the same, even for vaccinated individuals.
Right.
Also, it's worth noting, individuals who are HIV positive have different, more aggressive screening guidelines. They usually start earlier and get screened more frequently, reflecting their increased risk.
Right. Important distinction. Okay, let's shift to prostate cancer screening.
A big topic. Prostate cancer is the second most common cancer in men and a leading cause of cancer death among them.
And the risk factors. Age again.
Age is the most important, definitely. It's actually quite striking. Autopsy studies show about 2/3 of men over 80 have some form of prostate cancer, even if it never caused symptoms.
Oh, how? 2/3.
Family history is also a strong factor, second only to age, roughly doubling the risk. And African American men have both a higher incidence and a higher mortality risk.
Okay. And the screening options are the PSA blood test and the digital rectal exam, DRE.
Those are the two common ones, yes. The DRE's role as a standalone test isn't perfectly clear, but it's often done. The PSA test is widely used, but it's imperfect.
Imperfect how?
Well, a common reason for a moderately elevated PSA, say, between 4 and 10 nanograms per milliliter, isn't cancer. It's often benign prostatic hypertrophy, or BPH.
Just an enlarged prostate.
Exactly. Non-cancerous enlargement. Other things can also temporarily raise PSA levels, prostatitis, inflammation, ejaculation, even vigorous bike riding shortly before the test.
So a high PSA doesn't automatically mean cancer.
Definitely not. And maybe even more confusingly, there's no PSA level below which there is zero risk of cancer. Studies show about 15% of men with a normal PSA, less than 4.0, actually have prostate cancer if biopsied.
So it can miss cancers too. That is complicated.
It is. And this complexity, combined with the potential harms of screening and treatment, that's why there's so much emphasis on shared decision-making.
Harms like what? Overdiagnosis again?
Overdiagnosis is a big one, finding cancers that would never have caused harm. And then overtreatment, leading to potential side effects like incontinence or erectile dysfunction. These can significantly impact quality of life.
So it's a really tough balance. How do the different professional groups guide that shared decision-making talk?
They approach it slightly differently, reflecting different weighing of the evidence. The USPSTF 2018 recommends shared decision-making specifically for men aged 55 to 69. They emphasize the small potential benefit of reducing prostate cancer death versus those potential harms.
Small benefit.
Small absolute benefit, yes. And they actually recommend against routine screening for men 70 and older, feeling the harms generally outweigh benefits then.
Okay. What about the cancer or urology groups?
The American Cancer Society, ACS 2023, also pushes informed decision-making, but they suggest starting the conversation earlier based on risk. Age 40 for very high-risk men, like those with multiple first-degree relatives diagnosed young.
Age 40 for the conversation.
Age 45 for high-risk men, like African-American men, or those with one first-degree relative diagnosed before 65. And age 50 for average-risk men. They also say stop screening when life expectancy is less than 10 years.
So more tailored start times for the discussion.
Yes. And the American Urological Association, AUA 2023, is similar, emphasizes shared decision-making, suggests high-risk men discuss screening starting at 40-45, average risk at 45-50. They also suggest stopping around age 70, but individualizing based on health. And importantly, they recommend screening intervals of every 2 to 4 years, not necessarily annually, and repeating an elevated PSA before jumping to a biopsy.
Repeating the PSA seems sensible, given those fluctuations you mentioned.
It does.
So the big takeaway here isn't a single age or number. It's really about the shift towards truly personalized discussion, weighing your individual risks and your values about potential harms versus benefits.
That's exactly it. It's a prime example of applying the why we talked about earlier to the what of screening.
Okay, one more screening area. lung cancer screening.
Yes, and this one is critically important because lung cancer is still the leading cause of cancer-related death in the United States for both men and women.
Then leader. But there's effective screening now.
Yes, thankfully. The National Lung Cancer Screening Trial, the NLST, was a landmark study. It showed a significant 20% mortality benefit from doing annual low-dose CT scans for eligible individuals.
A 20% reduction in deaths, that's huge.
It is a major breakthrough.
So who is eligible? Who should be having this conversation?
Both the USPSTF, as of 2021, and the ACS, as of 2023, largely agree on the core criteria. You need to be a current or former smoker.
Okay.
You need to have a smoking history of at least 20 pack years.
And remind us, what's a pack year again?
A pack year is smoking an average of 1 pack, 20 cigarettes per day for 1 year. So 2 packs a day for 10 years is 20 pack years, or 1 pack a day for 20 years is 20 pack years.
Got it. 20 pack years minimum and age.
And be between 50 and 80 years old.
So 50, 80, 20 plus pack years, current or former smoker.
Those are the key criteria for eligibility.
Are there any differences between the guidelines?
There is one notable difference regarding former smokers. The USPSTF recommends stopping screening once someone has quit smoking for 15 years.
Okay, 15 years quit, stop screening.
Whereas the ACS does not include that 15-year quitting cutoff. Their guideline implies continuing screening as long as the person meets the age and pack year criteria and is healthy enough.
Interesting difference. And are there risks with the screening? Radiation?
There are potential risks, yes. Radiation exposure for the CT scans, though it's low dose.
Yep.
And also the issue of incidental findings, finding nodules or other things that turn out to be benign but might lead to anxiety, further tests, even invasive procedures.
So harms again?
Yes, but the crucial point is that the mortality benefit has been clearly demonstrated in large trials. So for people who meet the criteria, it's again about that shared decision-making conversation with your doctor, weighing the confirmed benefit against these potential risks.
Definitely a conversation worth having for anyone who fits that profile.
Absolutely.
Okay, let's transition now. We've covered screening in depth. Let's talk about a critical preventable risk factor that underlies so much of this, particularly lung cancer, but much more besides smoking. What's really striking here is just the sheer scale of its impact, but also, importantly, how much control we potentially have over it.
Smoking is, and it's hard to overstate this, the single most important cause of preventable morbidity and mortality worldwide.
Worldwide?
We're talking an estimated 5 million excess deaths every single year globally due to smoking.
5 million? That's staggering. What about here in the U.S.?
In the U.S., estimates are around 23% of Americans aged 12 or older currently smoke or vape nicotine.
23%. Still quite high.
It is. And disturbingly, most people who smoke start before they even turn 18.
Before 18? Why do kids start? What are the influences?
Well, there are several factors, especially for adolescents. Peer influence is a huge one.
Yeah, friends smoking.
Family factors play a role, too, having smokers in the family,
Yep.
peer communication. Personal factors like learning problems or depression can increase risk. And we absolutely cannot ignore the impact of tobacco industry promotional activities.
Advertising and marketing.
Yes. On the flip side, societal measures do work to reduce smoking. Things like increasing taxes on tobacco products and implementing smoke-free workplace laws have been proven effective.
So policy makes a difference.
A big difference.
What about nicotine itself? What does it do?
Nicotine is pharmacologically a mild stimulant. It increases alertness, can improve attention, and it decreases appetite.
Decreases appetite.
Yes. But the real challenge, the reason it's so addictive, is the withdrawal syndrome when you try to stop.
Ah, withdrawal. What does that feel like?
It's unpleasant. Intense craving for nicotine, irritability, anxiety, difficulty concentrating, restlessness, even a slowed heart rate, and that increased appetite we mentioned.
So you get hungrier when you quit.
Yes. And while most of the mood symptoms, the irritability, anxiety tend to subside within about a month.
Okay, a month.
That increased appetite and the potential for weight gain can persist for 6 months or even longer. That's a major barrier for a lot of people trying to quit.
6 months. Yeah, I can see how that would be tough. Now, the health complications. We know lung cancer, obviously, but it goes way beyond that.
Oh, far beyond. The list is incredibly long. Let's just hit some major ones. Cardiovascular. Smoking is a huge risk factor for heart attacks, strokes, aortic aneurysms, peripheral vascular disease, poor circulation in the legs.
Okay. Lungs, besides cancer.
Pulmonary.
Yeah.
It's the main risk factor for chronic obstructive pulmonary disease, COPD, emphysema, and chronic bronchitis. Estimates suggest maybe half of all long-term smokers will develop COPD.
Half.
Wow. And if you're diagnosed with lung cancer, continuing to smoke actually shortens your survival. Plus, it increases your risk and the severity of infections like pneumonia and the flu,
What about digestion? Gastrointestinal?
associated with esophageal and pancreatic cancers. Also linked to peptic ulcer disease, especially if you also have H. pylori infection, and it worsens gastroesophageal reflux disease, or GERD.
Heartburn. Okay. Head and neck.
Increased risk of squamous cell carcinoma, those cancers of the mouth, throat, larynx. And that risk is dramatically higher if you also drink alcohol heavily.
Smoking and drinking together, very bad for head and neck cancer.
Very bad combination there. Skin. Smoking leads to premature aging, more facial wrinkles. The effect is similar to excessive sun exposure.
Wrinkles. That might motivate some people.
It might, and genitourinary. It can accelerate the decline in kidney function, increases the risk of kidney cancer, renal cell carcinoma, and bladder cancer, and it's a known cause of erectile dysfunction in men.
It really affects pretty much every system.
Virtually every system in the body. But, and this is the crucial message of hope quitting works.
Tell us about the benefits of quitting.
Quitting smoking leads to significant, measurable health benefits. Your overall mortality risk starts to decline significantly within just 5 years of quitting.
5 years.
And eventually, maybe after 15 or 20 years, your risk can approach the level of someone who never smoked.
That's incredible, even after smoking for years.
Even after smoking for years. And even if someone has already developed COPD, quitting still helps. It will slow down the rate at which their lung function declines. It's never too late to get benefits from quitting.
That's such an important message. It's never too late.
Never. And one more thing to reiterate. Those low-tar or light cigarettes, they are absolutely not safer.
Just a marketing gimmick.
Pretty much. People often unconsciously compensate by inhaling more deeply or smoking more cigarettes. There's no safe cigarette.
Okay, so knowing all these devastating effects and knowing the benefits of quitting, what actually works? What are the best evidence-based ways to help someone quit?
Great question. We need to talk about actionable steps.
Yeah, let's get practical. What does the evidence show?
Well, the U.S. Department of Health and Human Services recommends a counseling strategy called the 5 A's. It's a framework mainly for healthcare providers, but it's useful for anyone to understand what good support looks like.
Okay, the 5 A's. What are they?
First, ACE-K. Systematically identify all tobacco users at every encounter. Make it routine.
Just ask everyone.
Second, advise. Strongly urge all tobacco users to quit. The advice should be clear, strong, and personalized. Linking it to their current health or concerns, like maybe quitting now could help you recover faster from this flu.
Make it relevant. Okay. Third,
assess. Determine their willingness to actually make a quit attempt right now. Are they ready?
assess readiness.
Fourth, assist. If they are ready, help them. This means setting a quit date, helping them identify support systems, anticipating challenges like withdrawal or triggers.
So practical help. And the 5th A.
Fifth, arrange. Schedule follow-up contact. This could be in person or by phone, ideally starting within the first week after their quit date. That's often the toughest time.
Ask, advise, assess, assist, arrange. The 5 A's.
Exactly. And research shows that even brief advice from a physician does increase quit rates.
Just bringing it up helps.
It does. And interventions seem to be even more effective for patients who already have a smoking-related illness. They might be more motivated then.
That makes sense. Now, what about medications? Does therapy help?
Absolutely. Pharmacotherapy, used alongside counseling, significantly boosts the chances of successfully quitting. They work best together.
Okay, what are the main options? Nicotine replacement.
Yes, nicotine replacement therapy, NRT, is a cornerstone. It comes in various forms: gum, patches, lozenges, nasal spray, inhalers. They deliver nicotine to reduce withdrawal symptoms without all the other toxins in smoke.
And does it work?
Yes. NRT increases long-term cessation rates by about 60% compared to placebo or no NRT.
60% better odds. That's significant.
It is. Higher doses might be needed for heavier smokers. And sometimes combining a long-acting form, like the patch, with a short-acting form, like gum or lozenge for sudden cravings, can modestly improve abstinence rates even further.
Mix and match. Is it safe?
Generally, yes. There's very little evidence of serious safety issues with NRT when used as directed.
Okay. What about e-cigarettes for quitting? That's controversial, right?
It is controversial, but the evidence is evolving. Recent studies, including large reviews, actually suggest that e-cigarettes are effective for smoking cessation.
More effective than NRT.
Some studies suggest they might be more effective than NRT. One analysis found a number needed to treat of 4, which is quite good.
Number needed to treat of 4, meaning you only need to treat 4 smokers with e-cigs for 1 extra person to quit successfully compared to NRT.
Compared to placebo, yes. Or showing superiority over NRT in some head-to-head trials. And while the vapor does contain toxic substances, the levels are generally much lower than in cigarette smoke.
But there are downsides, concerns.
Definitely. We saw those cases of severe lung injury, E-vol-I, mostly linked to vaping THC products, often obtained illicitly. And there's growing concern, especially on public health officials, that e-cigarette use, particularly flavored ones, can be a gateway for young people who never smoked to start using nicotine and potentially transition to traditional cigarettes later.
So effective for existing smokers to quit, maybe, but potentially risky for youth initiation.
That's the complex picture right now. It's still being heavily researched and debated.
Okay. Other medications. Bupropion.
Yes, bupropion, which is also used as an antidepressant, is FDA approved specifically for smoking cessation. It works differently from nicotine. Studies show it increases the odds of quitting, with a pooled odds ratio around 1.6.
So it helps. Side effects.
Common ones are things like insomnia and headache. Some research suggests that using it for longer periods, like a year or more, might help prevent relapse in some people.
Okay. And then there's varenicline or Chantix.
Right, varenicline, Chantix. This one works as a partial agonist at nicotinic receptors in the brain. So it does 2 things. It reduces the craving and withdrawal symptoms, and it also blocks the rewarding effect if someone does smoke while taking it.
Kind of blocks the buzz.
Exactly. And studies consistently show it's more effective than bupropion, and generally more effective than NRT alone.
So possibly the most effective medication.
Based on current evidence, yes. Often considered the most effective single pharmacotherapy. The main side effect is nausea for some people. There were initial concerns about serious psychiatric side effects, like depression or suicidal thoughts, but larger follow-up studies haven't confirmed an increased risk compared to placebo or NRT.
That's reassuring.
Yes, the FDA even removed the boxed warning related to that a few years ago.
So to wrap up this section on quitting, what's the absolute best approach? Is it just picking one of these?
The clear consensus from all the evidence is that the most effective approach is combining counseling with pharmacotherapy.
Counseling plus meds.
Yes, that combination consistently yields the highest quit rates. There was a striking randomized trial in smokers who were at high risk because they already had cardiovascular disease.
What did it show?
Compared to just usual care, the group that got intensive counseling plus their choice of pharmacotherapy had dramatically higher quit rates at 2 years, 33%, versus only 9% in the usual care group.
33% versus 9.
And even more importantly, they had significantly lower all-cause mortality death from any cause 3% versus 12%.
Wow. So it didn't just help them quit, it literally saved lives in the short term.
Absolutely.
Yeah.
It powerfully demonstrates the impact of combining these evidence-based strategies.
That's incredibly powerful. Okay, as we bring this deep dive to a close, let's just circle back to where we started. That feeling of being overwhelmed by health info. Hopefully, by digging into the nuances of cancer screening, understanding those biases, why guidelines might differ, and by really looking at the comprehensive strategies for smoking cessation, from the risks to the proven quitting methods, you feel better equipped.
That's the goal.
Equipped with actionable, impactful knowledge.
And if we connect this to the bigger picture, this kind of knowledge really empowers you, doesn't it? It helps you become a more informed advocate for your own health.
Yep.
Well, you can have much more productive conversations with your doctors. You can critically evaluate that next health headline you see. You can make decisions about screening or lifestyle changes that truly align with your values and your health goals.
Because you understand the why behind the recommendations.
Exactly. There's always more to learn, of course, but applying this kind of knowledge, that's where the real value lies for your health journey.
So as we leave you today, here's a final thought to maybe mull over. What stands out to you from today's deep dive? What's one thing you'll remember the next time you hear about a new health recommendation? Or maybe think about a lifestyle change for yourself or someone you care about.
Keep that curiosity going.
Yeah. Keep digging, keep asking questions, and stay engaged with your health.